Payers use data that they have within their own four walls often to make decisions on which treatments should be covered and which treatments shouldn't be covered. As value assessments have started to mature from other independent organizations, payers have looked to those other organizations to incorporate sort of the output of their analyses into their payer decision making. I would say, though, that we're still at intermediate stages of how those external value assessments get incorporated into payer decision making, and we trust within payer organizations our own analyses to a greater degree today. So I think it's absolutely critical that as soon as there's a hope for a new treatment, or even some debate over which of the existing treatments should be used, and any kind of differential information that would be used by a decision-making body to determine which one should be preferred or covered, that patient organizations proactively go to payers as well as to the independent organizations such as ICE are conducting the value assessments to figure out where are the gaps that they see in the existing knowledge that is out there and in the literature or in guidelines on how well the drugs work, or the treatments work relative to each other. So I think the short answer is how do I suggest that they engage payers? I think it's multimodal. There's lots of different channels. I think being proactive directly is important, and some payers have an open door for that. I think being able to sort of understand who the payer organizations are turning to for additional information and going to those organizations is not only the value assessment organizations, it can be other consulting organizations, coalitions of commercial employers, et cetera. Those are the folks that have influence over many of the things that you would like to interact directly with payers on, but payers don't have the capacity to have 50 different organizations coming to them and engage in a conversation with all of them. We're at a critical inflection point right now because not only are there so many high-cost therapies that have come out, but a comment that's been made by many, including myself, from time to time over the last decade has been that the day is coming where we have to make macro-level trade-offs between therapeutic classes, between totally unrelated clinical conditions, just because in a budgeting cycle you only have so many dollars in a plan in order to cover sort of something for everyone. I think that day is here, and I think those decisions are being made on trade-offs more often than many people would like to believe today, because you're operating under a relatively fixed budget, and there's more pressure than ever to not raise premiums, for different, especially commercial plans. So that day is here, and we all have to reckon with that and figure out, how to get the best amount of information and data together to help us make those trade-off decisions, so that truthfully the real, sort of critical breakthrough therapies that are have the potential to change patients' lives, and the great science that's being done is able to get to people. And I think that's what gets lost in the discussion about access is we all fear, I think, not allowing patients, families access to new life-saving therapies. And we think that that's not happening. It's happening because those trade-offs have to be made because there are only so many resources to go around. And so like it or not, that's already occurring. What we need to do now, I think, and the criticality of the time that we're in, is that there are more and more things that will, without a better system, without a better and more focused attempt to, for all of us to kind of, understand where the gaps are and understanding what benefits people, whether it's, benefits the family on caregiver burden, whether it's something that wasn't studied in the clinical trials on, the effect of comorbid mental health disorders for a treatment and how low patients' adherence is. All of those sorts of things we need to do, we can and I think need to do better in filling those gaps so that we can understand which things should, be under the line, so to speak, and be included and covered. And if premiums have to be raised and we have to pay more for healthcare because there are so many great new developments, then that's a different conversation that we have to have.